Welcome to Podcasts on Demand, a continuing medical education activity. This activity includes the most recent and current clinical data presented by leading experts. If you are seeking continuing education credit, please review the disclosures and the requirements for successful completion of the activity prior to listening to the podcast. A link is found in the podcast description that can direct you to this information.
So I will quickly move on to this first case here, and then I'll pass it off to Dr. Bardia. We have a 55-year-old woman with a large right breast mass, has a biopsy of the breast mass and bulky right axillary lymphadenopathy, and she's found to have triple-negative breast cancer, ERPR0, HER2 1+. She has a metastatic workup that reveals liver metastases. Her blood work is relatively normal with some mildly elevated transaminases. She has germline genetic testing that's negative, and she has PD-L1 testing that reveals a combined positive score of greater than 10. So what would be your first-line treatment choice for this newly diagnosed patient with metastatic triple-negative breast cancer? Would it be TDXD? Would it be SG? Would it be paclitaxel plus pembrolizumab, carbo plus gem, or you're unsure? So remember, BRCA1/2 wild type, PD-L1 positive. And we've got a little bit of a smattering of things here. But I think the best choice for this patient would be paclitaxel plus pembrolizumab. She has PD-L1 positive disease, a combined positive score of greater than 10. And we know that pembrolizumab plus chemotherapy is associated with a significant improvement in overall survival, so about 7 months. So I think selecting the appropriate initial therapy here for me would be focused on her PD-L1 positive status. She is a candidate for immunotherapy, and we definitely want to incorporate that into frontline settings. So thinking about, treatment planning for patients with comorbidities, obviously that is very important to think about for our patients. This patient was quite healthy and had PD-L1 positive disease, no reason to not give her the best therapy that we've got in that frontline setting. And so with that, in the interest of time, I'm going to let Dr. Bardia take over to talk a bit about side effects.
Excellent. Thanks so much, Dr. Nanda. So now I'll focus on managing treatment-related side effects, and then we'll finally talk about resistance as well as sequencing. So we'll start with the polling question. Which side effect management strategy do you feel needs more integration into TNBC treatment protocols? Pharmacological interventions, supportive care, nutrition support, or psychological care? Please send in your answers. Yeah, very interesting. So it looks like, all of these are important, which is true. From a patient perspective, we need to provide, better supportive care, nutrition support, psychological care, and also medications, which we'll review related to these drugs. So let me first start with immune checkpoint inhibitors. Those are the recommended first-line treatment option in combination with chemotherapy for PD-L1 positive metastatic TNBC, as was reviewed by Dr. Nanda. Immunotherapy pretty much can affect any organ. So you can have endocrinopathies with thyroiditis, hypothyroidism, hyperthyroidism. You can have adrenal insufficiency. You can have autoimmune diabetes. You can have impact on the liver with hepatitis, impact on the GI tract with colitis, impact on the bone marrow with myelosuppression, including hemolytic anemia, the CNS, as well as the lung with pneumonitis. In terms of common side effects that are seen with immunotherapy, if I were to list 5, those would be thyroiditis, hyperthyroidism, pneumonitis, enterocolitis, hepatitis, and rash. And these are side effects to remember, but any organ can be affected with immunotherapy. The key is recognition and management with steroids, as well as replacement therapy if appropriate. So if a patient has hypothyroidism, doing the appropriate replacement therapy. It's important to educate the care team, have a multidisciplinary approach related to management of these AEs. The timing can be very variable. IR AEs can occur months and sometimes up to a year after the end of treatment. And this time course might be even more variable with a novel combination. So if in any patient who's received prior immunotherapy, it is important to consider IRAEs. In terms of management, if a patient has grade 1, which would be mild, the recommendation would be symptomatic therapy. For grade 2, start oral steroids. For grade 3, grade 4, start intravenous steroids. Generally, grade 2 and beyond, we would hold treatment. For some AEs, you can start treatment before the resolution, for example, with rash, as opposed to, say, a patient has colitis. So it's also a bit dependent on the type of IRAE. And then consider referral to a specialist, especially if the IRAE is grade 3 or higher. But in the appropriate circumstance, such as for grade 2 pneumonitis, it's very reasonable to discuss that with the pulmonologist. The presentation can be very variable. As I mentioned previously, endocrinopathies, rash, pneumonitis, colitis, hepatitis, they account for more than 90% of IRAEs, but pretty much any organ can be affected. The oncologist would likely be the first one who is made aware of the symptom because this would happen after therapy and the patient would reach out to the oncologist, but it's reasonable to have a multidisciplinary approach. Generally, steroids are very effective. Long steroid tapers are often needed, so that's 4 to 6 weeks, sometimes even 8 to 12 weeks for things like pneumonitis, which require a long taper. In terms of antibody-drug conjugates, we have two that are approved, as was reviewed previously, sacituzumab govitecan and trastuzumab deruxtecan. Both of them have TOP1 payload. Some common side effects with these ADCs include myelosuppression. Both of these drugs cause myelosuppression, as well as alopecia. The frequency varies. With sacituzumab govitecan, myelosuppression or neutropenia is the number one side effect. More than 50% of patients would have grade 3 or grade 4 neutropenia without GCSF support. So that's why, in general, secondary prophylaxis with GCSF is recommended, which we'll review in the appropriate circumstance. Some would even consider primary prophylaxis, although the common scenario is secondary prophylaxis. It can also cause diarrhea, which is the second most common side effect with SG, as well as fatigue and alopecia. With TDXT, nausea is the number one side effect that would occur in majority of the patients. In general, we recommend a 3-drug antiemetic regimen for primary prophylaxis. Can also cause myelosuppression. Serious AEs that are seen with TDXT include pneumonitis, range of 10 to 15% in clinical trials, all grade. Generally, something that's not seen with sacituzumab govitecan. So let's talk about the pre-medications. As I mentioned, for TDXT, 3-drug combination regimen is recommended to prevent nausea. The starting dose is 5.4 milligram per kilogram every 3 weeks. If a patient has infusion-related reaction, you could consider dose reduction, or for other AEs, consider dose reduction. The first dose reduction would be 4.4 milligram per kilogram, second 3.2 milligram per kilogram, and then third discontinue. With sacituzumab govitecan, it's 2 to 3 combination regimen for prevention of chemotherapy-induced nausea vomiting. My personal practice is to consider a 3-drug combination regimen. 10 milligram per kilogram, day 1, day 8, every 21 days. In terms of reduction, first dose reduction 25%, second 50%, and third discontinue. In terms of management of fatigue, which can be challenging, the first would be to treat things that are treatable. So if the fatigue is coming from anemia, considering an RBC transfusion. Outside of things that are easily reversible, could consider non-pharmacological options, light to moderate exercise, which sometimes can be difficult for patients, especially in the metastatic setting, but certainly something to consider. And then other strategies like CBT, yoga, and other, if you will, easier forms of exercise, if appropriate for the patient. Psychological interventions, as well as counseling to patients and caregivers. The recommendations are for energy preservation, task prioritization, activity pacing, as well as advise how to delegate less important activities. In terms of nutrition, which is often a big question from a patient perspective, general recommendations for fruits, vegetables, lots of fluids with these therapies, and then general behavior techniques. As I mentioned previously, with IR AEs, but AEs in general, a multidisciplinary approach to management of adverse events is always helpful. And that's a partnership with pharmacists, infusion nurses, oncologists, other specialists like pulmonologists, dermatologists, as well as with the nurses, including nurse practitioners. So, in the final few minutes, I'll talk about treatment resistance and recurrence. We'll start with a case study. This is a 40-year-old patient with triple negative breast cancer. The patient received neoadjuvant chemotherapy, ACT carbo plus pembrolizumab as per the Keynote 522 regimen, then had surgery, had a nice response. There was some residual disease, it was still triple negative, and then received adjuvant capecitabine with pembrolizumab. Unfortunately, after the completion of pembrolizumab, the patient had disease recurrence. It was still triple negative, PD-L1 negative, germline BRCA mutation testing was negative. As was mentioned previously, these are the biomarkers we look for: PD-L1, BRCA status, and these days HER2 as well. The patient received first-line therapy with carboplatin, had disease progression after 9 months. The first question is, what would be your choice of treatment for this patient with metastatic TNBC who has HER2 IHC 0 TNBC? Trastuzumab deruxtecan, eribulin, navalbine, sacituzumab govitecan, or unsure? Please send in your answers. Yes. So ADCs are very exciting. A lot of interest in ADCs. For this patient with metastatic TNBC, I'll go back to the case. The HER2 IHC was 0. So in general, TDXT would not be a drug that's approved in this setting. The drug that's approved in the second-line setting would be sacituzumab govitecan for this patient. If this was HER2 IHC 1 plus 2 plus, which would be HER2 low, then TDXT would be another option. But for this patient, because HER2 IHC is 0, the appropriate option would be sacituzumab govitecan. So let's talk about how do I select therapies in the second line setting? The signals I look for, the second line setting, and how do we balance hope and realism? So essentially, the key is in the second line setting, we look at potential options that are available, the efficacy and toxicity. For a patient with HER2 IHC 0, in general, sacituzumab govitecan is the preferred option. But if a patient has HER2 low disease, then you have TDXT as an option as well. How do we decide between these options? It's a matter of the sequence of these drugs. One is given day 1, day 8, the other one every 3 weeks, different side effect profile. So discussing the advantages, disadvantages, the risk effect profile, those are important considerations when we talk about these drugs with patients. In terms of unanswered question, a big question in the field right now is sequencing of ADCs. We reviewed a case of HER2 low metastatic TNBC. If we start with SG, can I then use TDXT after that, or vice versa? Will these ADCs work if we have similar payloads? Both SG and TDXT have TOP1 inhibitors as the payload. Do we need other payloads? What's the best way to combine and sequence these drugs? So these are all open questions at this time. There are ongoing studies, prospective trials to answer these questions. So for the next few minutes, I see some Q&A coming in as well. Please send in your questions via the chat function. We'll review the questions. I'll start with therapies that are most promising and the role of targeted therapies over the next few years. There's a lot of interest in ADCs with newer targets, targets such as B7H4, there's HER3 as well. So there's a lot of interest in novel ADCs. Similarly, a lot of interest in other ways to activate the immune system, to remove the brakes away. We have PD-L1 inhibitors, but then there are other immunotherapy agents as well. And the key again would be to combine these drugs, but ensure that we can balance efficacy and toxicity. We'll get opinion from Dr. Nanda as well in terms of the therapies that you're most excited about and how to incorporate these exciting therapies in clinical practice.
That was great, Dr. Bardia. I think there are some questions. Have you seen significant response of a single agent chemo after ADC progression. I don't know, Dr. Bardia, if you wanted to address that question and if you've seen that in your practice.
Anecdotally, yes, but overall, in general, after ADCs, the prognosis is not that great. And we have data from real world studies, including looking at ADC after ADC. The second ADC after the first ADC does not perform that well. And similarly, in general, chemotherapy does not perform that well. And that's from real world data set, as well as studies like ASCENT, when the team looked at how patients did on eribulin or capecitabine after SG. It was not great, but at the end of the day, we'll use the options that we have available. But in this setting, I would strongly recommend clinical trials to consider if that would be an option for the patient.
Yeah. No, I completely agree with you. I've definitely seen some responses, but definitely not what we saw prior to ADCs. And I think the responses that we've seen with chemotherapy really pales in significance to what we see with the ADCs. And so I'm really excited about the future of ADCs in the management of patients with breast cancer, some of these novel agents that we've touched on briefly, and a whole host of others that are in clinical development. Another question that came out was, what role do you see immunotherapy playing in reshaping the treatment and landscape for patients with triple negative breast cancer over 5 years? I don't know what your thoughts are there. Happy to share some thoughts as well.
Yeah, I can start. Immunotherapy is being used in early breast cancer, and I think that's there to stay. What will change is likely the chemotherapy partner instead of chemo using ADCs. And probably we'll see immunotherapy based combinations. Right now, we only have PD-1 inhibitors that are approved, but probably combination of different immunotherapy agents will be something that we'll see over the next few years.
Yeah, I agree. And not just combination strategies like an anti-PD-1 with a TIGIT or LAG-3 or things like that, but a lot of the bispecifics are looking very promising. And so, whether there's an anti-PD-1 VEGF or an anti-PD-1 TIGIT bispecific antibody, I think that may be the next wave of immunotherapy type trials that we're going to be seeing in both metastatic and even at the early stage setting. So a lot of promise there too. So I do think that we've made progress in terms of immunotherapy, maybe not as much as we would have liked, because again, it's a small proportion of patients with TNBC that seem to benefit from the addition of immunotherapy to chemotherapy. But I wholeheartedly agree, ADCs are going to displace traditional chemo in those combination chemo immunotherapy type roles. But then I think the next wave of studies will be potentially dual checkpoint blockade or bispecific therapies. It looks like maybe we'll have one more question here that we haven't addressed. Do non-BRCA HRD mutations in triple negative breast cancer respond to PARP inhibitors? We have seen some data from TBCRC 48, which was a trial called olaparib expanded, which looked at olaparib in patients with germline alterations in other DNA repair pathway genes, as well as in somatic BRCA1 and 2 associated breast cancer. So not germline, but tumor-associated BRCA1 and 2 mutations. And in that study, we did find that patients who have germline PALB2 mutations have a very high response rate and improvement in PFS, or a significant response to olaparib, and as well as somatic BRCA1 and 2 tumors did respond to the PARP inhibitor olaparib. But the other germline alterations, we didn't really see much of a response. So I definitely think there is a role for olaparib in germline PALB2 mutation carriers. But I would like to point out 75% of those patients who have germline PALB2 mutations who develop breast cancer have a tendency to develop hormone receptor positive disease. So only a minority of those patients have TNBC, but absolutely something to consider for those individuals who have metastatic breast cancer in the setting of a germline PALB2 mutation. I don't know what your thoughts or experiences have been, Dr. Bardia, with other sort of HRD type assays and whether or not you've seen much benefit there with PARP inhibitors. I personally have not, but, I'm not sure if you're familiar with some data that suggests there may be a role.
I agree. And your TBCRC study, I think, was very helpful because it looked at different mutations, and essentially it was germline BRCA, somatic BRCA, and PALB2 where you saw responses with single agent PARP inhibitor. But outside of that, we don't see much responses. Excellent. So to wrap up, we know TNBC lacks ER, PR, HER2 is associated with higher risk of recurrence, poor overall survival. Traditional chemotherapy has limitation, but the landscape has changed now with immunotherapy, with PARP inhibitors, with antibody-drug conjugates, all of which are something to consider for a patient with TNBC. They've shown improvement in outcomes. It's important to test for these biomarkers, consider the drug, but manage the AEs, which sometimes requires a multidisciplinary approach. Moving forward, we need more research to understand resistance to ADCs, sequencing of ADCs, as well as building rational combinations, combining ADCs, immunotherapy, as well as newer agents. So thanks. And in terms of side effects, always would emphasize a patient-centered care, clear communication, personalized treatment plan, and providing support to patients. It's important that the patient experiences are acknowledged because that'll provide a holistic approach, including management of not just their AEs, but incorporating strategies that can improve quality of life besides survival. So thanks so much for joining today.
We hope you found this podcast useful and educational. To receive continuing education credit and to download your printable certificate, please go to the activity page at practice.cme.com to complete the post-test and evaluation to receive continuing education credit.